Good morning. So welcome to Coffee Conversations. As we settle in, I'm just going to go through our normal routine of just welcoming everybody as we are entering Friday Junior. So welcome to Coffee Conversations. This is an interactive discussion series hosted by the Academy of Communication and Healthcare. Some of you know, my name is Zafrina Rafi. I am one of the program managers for External Ed. Today, Calvin Joe is going to be my co-host, and we are joined by our featured guest, Elizabeth Spradley. And the Academy of Communication and Healthcare is a nonprofit academic community to support education, research, communication, and relationships in healthcare. And so for today's topic, we're going to be having a conversation around leveraging storytelling in relationship building. And so just as a reminder, unlike other webinars, these sessions, we want them to feel more like a conversation. And so we really do invite your engagement. So whether that is actively while unmuting or using our chat, our aim today is really just for you to be able to connect with your fellow colleagues. And so as a reminder for part one, this is more of an interview conversation with our featured guest, Elizabeth. And so part one is recorded and will be available for review later on our ACH Connect member site. And so for this part one, we do encourage you to mute your audio just so we can minimize distractions, and video is optional. And then we do invite you to use that chat feature with any questions or reflections you may have. And then part two, just to remind you, is not recorded. And this is where it's the more interactive breakout sessions where we're encouraging you to share your conversations with your fellow colleagues. And that's where we would encourage you to start your video and unmute your audio as you're able to. And so we hope you're able to stay for this full hour and engage in that part two conversations. And so with that, I'll pass it over to my co-host, Calvin.
Delighted to see everybody here. Thank you for joining us this morning. And I'm very excited personally to be able to have conversation and get to know Elizabeth Spradley some more so that we can find out more about her deep interest and passion in narrative and how narratives help us in healthcare. So welcome, Elizabeth.
Thank you. Thank you so much.
Very, very excited to have you here. So, our usual coffee conversations question that we begin with is ask to tell us where you're located, your morning beverage of choice, and what your professional work entails. And I have to share my morning beverage of choice first with you, so that you don't feel self-conscious, I suppose. So this is my morning beverage. It's not of choice. It is my current morning beverage, which is an energy drink, because I think that, after my workout, I should do this, but I don't know that it really helps. It's really more delusional, this drink. So I'm drinking Delusion this morning.
Excellent. Well, I am in Nacogdoches, Texas. So if anyone's joining from Texas, I'm on the east side, or if you're looking at a map of the United States, I'm on the east side of Texas, which is a beautiful pine tree area of East Texas. It's really pretty, very hilly. And I am basically a coffee drinker in the morning. Some people enjoy tea. I like a dark roast coffee from a French press is what I do at home. But if I'm out and about, I might pick up a cappuccino. That's my beverage of choice. But right now I have water because I've already consumed plenty of coffee for the day. And I actually come from a background in health communication, and I really enjoy and became interested in the scholarship that connected health communication with the practical implications for clinical environments. So
we're all eager to hear more about that as time goes on. If you say dark roast from French press, those, as a non-coffee drinker, I think, wow, she's like, that's serious. So sounds like you.
Well, it probably is. I mean, we stir it, and then we take the foam off the top, and we have the tea kettle with the French press setting on it. So I guess my household's pretty serious about our coffee.
I'm good. It's good to be serious about that sort of thing. If it's important to you. Maybe just a broad question to begin with, and that is, what brought you to your interest in communication in healthcare?
Definitely. I think that, as I suspect of many others, I had a pivotal personal moment with regard to the implications for health communication, for health outcomes, as well as healthcare satisfaction. As a young person, I watched my grandparents, through my pawpaw's experience with esophageal cancer,
Mm.
go through just the system of what is MD Anderson and working through oncology, but his providers made all the difference in the world. Their collaborative, team-based approach to healthcare, drawing out his stories and what his goals and dreams were. And at that time period in history in esophageal cancer, it meant the removal of his esophagus,
Mm.
and which was just very traumatic. And I was so impressed by the level of empathy and care, and that transformed my interest and my desire to learn more about health communication. And then in my PhD program at Texas A&M, I just became exposed to the works of narrative medicine through Dr. Rita Sharon's work specifically, and then some of my professors like Rick Street's work with interventions and training of medical students and different models of communication for healthcare, and Barbara Scharf's work with storytelling and narrative methods within clinical encounters. And I was inspired by Lynn Harder's writings that really blended health communication and medical humanities. And so I really just began that journey being personally motivated as well as inspired by the works of others, hoping that maybe I could be a part of what I felt was such an important aspect to communication in healthcare, and that was storytelling and story listening.
Storytelling and story listening. We'll get into that in a moment, because it sounds that sounds like a very, very important distinction. I'm really gratified, Elizabeth, to hear that you came into healthcare because of an inspiring experience with the healthcare system. So often we hear people going into something like this because they're trying to right a wrong, and it's really nice to hear that you had a positive experience, and you really want to further that. You mentioned storytelling versus story listening, and I wonder if you could delineate the two for us.
I think that the lines are probably blurred between them. Let's face it, if we're effective storytellers, we learn the components of storytelling, the ingredients of telling a good story, which makes us better listeners. And being a really effective, empathic, active listener is going to help you be a better storyteller. I think that there's a relationship clearly between the two, as there will typically are relationships between all of your communication repertoire. And so I don't think that the distinction is stark, but I do think that there are specific skills that really help, specifically with speaking and listening, that people need to gravitate towards as they're building their skill sets. And so with listening, I think a lot to the work in narrative medicine, whether you're looking at Rita Sharon's work or others, and they've done a lot to delineate what goes on in the clinical encounter to really prompt the storytelling of the patient and be an effective listener. And specifically in that area, there's three, you might say, stages. One is attentiveness, where you ask, you just have this open-ended ask, right? An invitation to storytelling. So I'm going to be your provider, you're going to be my patient. What do I need to know about you? What's your story? What do you want to share? So there's that prompting and open invitation, but then there has to be an accompaniment of really active, empathic listening for you to not only hear what's shared, but what's not shared. Where are the pauses in the story? Where are the omissions? What aren't you hearing? Because that's just as important oftentimes as what you are hearing. And so that is just a fundamental aspect of listening and not jumping to conclusions. Or I think that a lot of the work tends to indicate not trying to diagnose before you hear the whole story so that you get it comprehensively and contextually. But the other skills that are associated with that in the narrative medicine literature look at representation, and that really focuses on writing the patient's story. So having that opportunity to write about it. And There are different approaches in narrative medicine to the ways that you write the story. Some people incorporate images or pictures, and they ask and solicit from the patient or their families some pictures that can be included in the patient file, but oftentimes it is just a short written account that's shared even with patients, so that you have that opportunity for perception checking and to see if your representation not just is accurate, but it's almost a gift back to the patient that they've been listened to, they've been acknowledged, they've been heard, which bridges into the final step in that narrative medicine process, which is where you engage in affiliation, which is continued relationship building through the discourse of shared stories that are happening over time, and the collaborative storytelling that happens through the relationship. So I think that there are some distinctions, some specific skills that are related to the storytelling and the story listening, but at the same time, they have this nice, beautiful reciprocal relationship. When you're developing one, I think you're developing the other.
I love the way that you have delineated the aspects of the listening from a provider standpoint. I am very conscious, intentional with the open-ended question and the necessity to listen attentively. I know once upon a time my head was just full of other stuff, and so I wouldn't be listening as well, and I would do that more. But then these next steps, well, you talked about representation and then affiliation. Those are steps that I don't think I'm quite so intentional about. So it's really helpful to hear about those. I watch a lot of Graham Norton, the Graham Norton Show, and they do a lot of storytelling there. They actually focus on, like, I know how to tell a story, or at the very end they have this red chair thing where, I don't know if you know this, but people are trying to tell a story and they're being rated essentially on how they're telling their story, and if they don't like the way the story is going, then they flip them and then the red chair goes over. I wonder if I've always wondered, some of it is the content of the story. They don't like the content, and that's what flips them. But there's also something, I know that there's a way that they're telling the story that is more engaging and other ways that are less engaging. And I wonder if you could help us think about the ingredients. You mentioned this word before, ingredients of a good story.
Now, that's a great question. And while there's not one answer, I think that an overarching response to that begins with, are you transporting the listener into the story? So there's a theory out there by Green and Brock that looks at narrative transportation. And if you imagine some of your favorite movies or a novel that you pick up, what do you love about it? And it's probably that you get lost in the story, that you're transported into this otherworldliness. And that's because there are some components to narrative that, of course, are important. I mean, typically, if you were to say, well, what are the ingredients for a story? Well, you need characters, you need a narrative action, you need a plot, you need scenes, there's a chronology, there's typically a conflict and resolution, and there's some nuances within that, like different types of characters that surface, like adversaries and heroes and heroines that come in and save the day, or victims, and we can kind of go off on some of those kinds of things. But you have your typical ingredients, but it's how you tell the story, so the delivery elements to it. It's how you sequence the story that can help people to follow you or not follow you. And let's face it, all of us have more or less storytelling skills. So even if you as a provider develop storytelling skills, your patients may not have quite that level of storytelling skills. But if you are a good storyteller, you can help them along the way by helping them to think about, oh, chronology might have gotten off there. Can you tell me, did that happen first or second? You can help them along the way with maybe characters have been omitted from the story, but you're interested in how these other social interactions in their lives may be impacting aspects of their health. So there are ways that you can tease that out if you're familiar with those ingredients to assist with that storytelling process, so that you get a fuller scope and context for what's being communicated. And I love Jerome Bruner's work with narrative. It's really helpful in terms of just characteristics of narrative, but he harkens back to Aristotle, like, and we look back, and there has to be this peripetia. There has to be this rupture in the normal. And I think our tendency is to think that, okay, your symptoms or what made you ill is your rupture in the normal, and that might be the case, but it's not always the case. So being a good listener oftentimes is really needed to see what is it that's propelling that narrative. What is it that is really that rupture? Maybe it's the realization that a particular relationship has been harmed because of the illness, or maybe it's later on something is not being managed well and they're not being able to participate in certain activities that they loved once. And so sometimes the rupture is not what you think it is initially, and being a good listener will help with that, determining those things.
Wow. Yeah, my mind is swimming now with lots of potential ways of guiding. When you say guiding patients toward telling a better story, I guess you're saying, maybe being less judgmental than that, toward fleshing out their story more effectively, and then thinking about the omission places, because that's something that is sometimes it's hard for us to determine. From a healthcare, from a medical narrative standpoint, we want to know what the symptoms are and when it happened and all that kind of stuff. Those are clear pieces of the story that we can tease out. And at the same time, I think there's the broader system in which that story happens. It's not just about the patient's disease or illness. It's also about how that illness is affecting all the people around them. And maybe those are the things that we're not, as providers, asking patients as much about.
I think that's a really good point. Patients have the opportunity through their storytelling to really humanize themselves, to be more than just reduced to the disease metaphor for how the patient is seen. And providers have the opportunity to help them flesh out those narratives, as you eloquently put it, that will also humanize them through the process. So I think that what you pointed out is really important.
I love that point. The idea that oftentimes we are, as healthcare providers, we may be dehumanizing them, and we're putting them in a story of dehumanization. And then how can we inject that humanity into these stories? That's amazing. What do you think? How do you think that? How else do you think providers can be better at prompting stories from folks? We've already mentioned chronology. I imagine the adversary in these stories often is decreased function or emergence of a disease. I wonder whether in your learning and readings and research, what other aspects there are that providers can focus on.
I think that sometimes understanding what type of story a patient is trying to communicate and why they're communicating it is important as well. I think we have a lot of assumptions about people's communication. And so I think that Arthur Frank's work with narrative types can be really helpful in understanding, specifically with illness storytelling. And so those narrative types, you can ask yourself, is the patient communicating a restitution narrative? Are they seeking to restore the health that's been lost? Are they lamenting that lost health? And are they asking for you to come in sort of like as the hero heroine of the story and save the day? Is that reasonable? How do you need to collaborate with them on their storytelling to have a better understanding of what's going on and what's able to happen? It might be a chaos narrative that a patient is sharing, where that's very fragmented and there's a lot of frustration, and high uncertainty typically is characteristic of that chaos narrative. And if that's the case, it may be that helping them to manage the uncertainty through the way that the story is told and collaborated with through the patient encounter is really important. Also providing, maybe we can't provide a resolution in that encounter, but increasing their satisfaction with the encounter might help them feel a little less chaotic in what's going on in their health experience at the moment. And then maybe they're to the point where they're really seeking that quest narrative, where they're trying to find purpose in their new normal. And you have this opportunity to be a part of that, or and lead them to that, or help them to share their narrative with others, a way they can give back to a community of people that might benefit from their story. And so I think that kind of knowing the narrative type might be helpful. It might help you to ask different types of questions, relate to the patient differently, but also there are many different functions for storytelling in health context. And I love Reisman's book that's just a narrative methods book for the social sciences. It's through SAGE. It's not for healthcare. But at the beginning, there's this section that just talks about, why do people tell stories? Why? And it talks about things like, okay, they're managing and exploring their identities. They're trying to make decisions, so they're warranting or legitimizing the decisions that they're making. They're seeking or granting legitimacy for their experiences. They're making sense out loud through their stories of what's going on in their lives. They're making connections to other stories, or thinking about how those other stories shape their lives. They are trying to maybe persuade or advocate for some kind of change. And there's all these reasons that people tell stories, and getting to those motives can be really helpful, because it also gets to, well, what do you expect of me as a provider, and how can I help you? And sometimes you might be surprised by some of the answers that you get, or some of the layers of expectations that are there.
I'm mind is blowing a little bit right now, because you referred us to the TED Talk that Rita Sharon did a while ago, and she tells a story of a woman who has a recurrence of breast cancer, and she she goes through therapy. She has a mastectomy, and then is very, very worried about the recurrence of breast cancer even through that mastectomy. And what you're saying, Rita Sharon finally says that it's because she's afraid of death, rather than afraid of recurrent. It's not about the recurrence; it's about the glare of the possibility of death, and the fact that I'm going to be here holding that with you. So oftentimes in medicine, we think about the restitution story. So she was focused on that restitution, like, no, you're fine. And actually it's a quest story, right? Or maybe a quest story of, what is my purpose? Actually, my purpose is to hold this fear of death with you, right? I guess.
Yeah, I would say that on the provider side. Yeah. And then on the patient side, the patient seems to have a bit of unexpected chaos. You would think after the mastectomy that there would be that restitution, or that there possibly might be a renewed purpose, but instead seeming to sit in this high level of uncertainty about the future and concern about death that seems to be looming, despite there being no medical indication that it is. And so I think from the provider telling the story and then the patient perspective there, you see that they're almost telling two different stories rather than collaborating on the same one. And then there was that realization. And I think that's interesting, because we're all engaged in some sort of storytelling, regardless of our skill level or not. But to find that you're telling two different stories, that's pretty impactful in a moment of trying to connect with and affiliate with and represent a patient story.
I'm seriously getting goosebumps right now, thinking about all those times that I've rolled my eyes with a patient, like, I don't know what they want. I don't know what they want from me. And they're probably doing the same, because we're probably telling two different stories about each other. It's so interesting. Wow.
I think that just goes, communication bypassing happens all the time, where we bypass people and meaning. And not just in these kinds of encounters, but I'm sure, at home, communicating with family, or in the office, communicating with a colleague, you didn't realize it at the time, but you completely took away two different things from the situation. And I think that the moment of realization is that moment where we can work on it. We can begin to better collaborate, so that we're no longer bypassing each other.
I'm like really stimulated just thinking about all these things that I've learned from you in the last 20 minutes. And I wish we could talk forever. And I know one of the purposes of coffee conversations is the conversation part where everybody else comes in. I'm so grateful to you, Elizabeth, that lots of thoughts floating around my brain right now and wanting to learn more about these various narratives and how, because this is the work we do. Thank you so much. And